I'm going to move pretty quickly for the beginning part. This topic is single-tooth implants. Many of you have heard me lecture on it before, but it's evolving. And as Danny mentioned this morning, single-tooth implant is the most common implant you do, because remember that it was like 1.3 or something was the number per cases. That means that half, under 2, and this has been this way for years, under 2 implants. So you see all this great stuff we do. We all do these, or advanced teachers in the room and clinicians do these advanced cases. But the single-tooth implant is the #1 cases that you and I do, no matter how advanced you are in your office. So over 50% of all cases done in the world today are single-tooth implants. So we must learn how to do this properly. And I couldn't agree more with Dan. It depends on your expertise, of your level, of what you should do. You know, the early, the beginning, and advanced stages, the SAC. So we must pay attention to what you can do, not just you as an individual, but as a team. If you're only doing one part of it, you must have a team that does what you're going to see today. So let's go ahead. I'm going to go through the first part fast, because this should be, hopefully, old news already. And then go through some of the newer things that we'll be involved with, and some of the newer things. But we have to go through the basics, and then we'll take you mostly with when the extraction socket is intact. So Dana and I disagree with certain aspects, and we'll come to where that is. But let's go through this. You'll see why. You can lower the lights down a little bit now. So what we know, what we think we know, and what we do know, and what we don't know. I mean, this is really, everybody has their own opinions. All over the world, single-tooth implant is one of the most common lectures in the world today, isn't it? Because everybody's got their own potion. Think of all the variables. 1 is just how to take a tooth out. 2 is, where do you put the implant in? Do you do it immediately or not? 3, do you put a graft in? If you do so, what kind of graft? Should you put the implant forward, back, up, down, high, back, low? Should you put something that's resorbable in, something that's non-resorbable in? Should you put a piece of sashimi in there, as Joe Kahn says? Should you put a little sashimi in, a little connective tissue graft in there? Should we do that? Do we have to do that? So there's so many variables. Should we load it? Should we not load it? Is it in occlusion, out of occlusion, with a temporary, with a custom abutment, with a straight abutment? Whew. There are no variables at all, Think of all the things we just brought up off the top of my head. So let's go through some quick. First, lower the lights now, please. I want to give credit to my team. You saw Steve, of course, lecture earlier today. We got 5 prosthodontists, 2 periodontists, and 1 orthodontist with me. And it's a great team. We're partners, and I just tell you how great the team is. In every case I show you today, I did the surgery on, and one of them did the prosthetics on. So I want to give them great credit. And most of them today were mostly with Steve, and I want to give credit to my whole team. So we're going to talk about contour changes on extraction sockets, how to extract a tooth. I know that sounds funny, but we're going to do that, especially if you crack it or you fracture the root. How to place the implant. I think Danny did a great job of discussing it this morning. Should we place an implant or delay? I think that's a critical piece that we have to discuss based on the discussion today. And does gap size matter? Does it matter what the gap size is in the buccal? What do we know about it? What do we not know? So, and how does it change what we do in our practice? If we don't believe gap size matters, then you can do another whole dimension of what you can do clinically in your office. Once you're trained to do immediates, you can do other things, including molars. So we're going to get to that too and wind up with that. So let's take a look. And we will have hopefully a little discussion about flap design, which I added just for you, Dan. Okay, buccal contour. We've all seen this all day today. These are the problems we see. Now, the ceramics are good here, isn't it? The ceramics are fine on the bottom. So staining's lovely. But if you look at the problem, the problem is that the soft tissue is not in the right spot. It's too diminished in size. And so if this person had a high smile line, this would be a failure. So this is the way the patient came in, and she didn't like it. So we had to wind up redoing this for her. But the good news, the implant was fine, but we had to rebuild the soft tissue and bring the tissue down. That's not the point of today's lecture, but this is the most common mistake we see. And what was the main reason this happened? The implant was placed too far forward. Or the implant was placed when the buccal plate wasn't there. So choice is choice. Selection is the key. All sockets are not created equal, as we all know. And we've certainly seen enough of that all day today. Couldn't agree more. So everybody has different socket classifications. This is the one I came out with in the year 2000. And this was just simplified based on the buccal plate and being present or not with the soft tissue. Now, David, of course, and Henry and Maurice have a more expanded one. David Gelb has a more expanded socket one. But this is just real simple based on the buccal tissue and buccal plate. Type 1 is everybody's type 1 is the same. Take the tooth out, everything's there. Type 2 looks like type 1. But it's not like type 1 because part of the buccal plate's missing. If the bone is more than 5 millimeters away from the free gingiva, I call it the buccal free gingiva, I call it a type 2. Type 3, nobody gets into immediate trouble in the aesthetic zone because everybody knows you got to rebuild the tissue and bone and then do the implant. And that's obviously, in a high smile line, automatic. But type 2 is what you want to avoid. Today we're going to talk about type 1. There are 3 sources of blood supply to that buccal plate. There's the ligament, which is very vascular, by the way, and we just destroyed it. That's what's going to destroy the bundle bone. Exactly what Danny said and what Lindy's been talking about for years. The second one is the periosteum. And this is what I've been talking about. I've been on a tirade like this for about 5 years. So if you heard me lecture, you know I always say, do not take a tooth out by opening a flap. And nothing pleases me more than to hear that Danny wasn't opening a flap to take the teeth out. You've got to stop opening flaps to take teeth out, unless they're impacted. Because you'll see the difference in a minute. Because the periosteum is your second and major blood supply that's left. And yes, then you'll get collapse if you do that. You get collapse in. Because the marrow is almost non-existent in this thin cortical plate. It's, as we know, under a millimeter. So how thick is the buccal plate? As we know, they're very thin. Mariano Sanz and his group looked at this measurement. As we know from numerous people that have gone through this already, 64% were only a half a millimeter. And Danny's research on CAT scans verified this. And 23% were 1. So only about, as he said, 10% are greater than 1 millimeter. So if you go according to what Danny said, then only, and I agree with that, only 10% of the cases that you see, if you go with his criteria, should be immediates. But I'm going to disagree with that. I'm going to say something very plainly, because we've done it this way for 5 years. And we first were worried about thin scallop and thin bone on the buccal. If you get the tooth out and the buccal plate is there, they're all thin, or 90% of them are thin. And our results are the same for either way. That is not the criteria. As long as the buccal plate's there, don't play any game and say, well, it's halfway up, I got tissue, I'll play the game. No, that's incorrect choice. If the buccal plate's there, even with thin scallop tissue, we're going ahead with it. We're going to go for it. And you'll see why with our research. Now, this is what we saw. Many researchers have been research Schwab today. Look at this, 5.9 millimeters, Schwab. Buccal lingual dimension change is really the key. The vertical height is held up by the palate, so it's about a millimeter. But look at the buccal lingual dimension. That's unacceptable. Couldn't agree more. Unacceptable aesthetic results with 2 to 3, 4 millimeters of buccal lingual change. You cannot see 1 millimeter, by the way, with your naked eye. Get to 1.5 to 2, you're looking at it. You can start to see flattening, dark shadows, all the stuff that Uli Grunder talks about for years. He's correct. You get to 2 millimeters or more buccal lingual change, that's what you see. So if this was true, no immediate socket should be done, because this is terrible. But I looked at it and said, that's not what we're seeing. That's not what other people have done with immediates before I started getting involved about 5, 6 years ago. What was the difference? When I went back and looked at all this research, what did they do? They opened flaps. Every one of these studies opened flaps. So here's an interesting question for you. What happens if you don't open a flap in a human? What data do we have? And there's very limited data, but it's out there. It started with Uli Grunder in his control. If you start to look at this, Uli was the first one to, I think, show this, was really about 1 millimeter. If you place the implant into the palate, just like Danny pointed out, and you don't put anything in the gap, and not even a provisional, he showed 1 millimeter change in 6 months. Look at these numbers. Ernesto Lee's here. He did an article. He shows what the CAT scan was only a 1/10. 1/10. 0.8. This was 1.3. Some of them put grafts in, some of them didn't in the gap. But what was the main reason that I'm pointing this out? These were all flapless. They're all flapless. No flaps. You open the flap, you interfere with the periosteal blood supply. And even though you put it back and you grade suture, oh, you do 5-0, you do 6-0, you do 7-0. Dr. Turner, let me show you. I do 7-0 chromic, I do 7-0 silk, I do 7-0 micro. You do all this stuff. And you say, and I use a microscope, Dr. Turner. I use a microscope. Oh, good, good, good. You use a microscope. But you opened the flap. Now, you hid what you did because you sutured it back. I said, and whenever somebody does that, and they say, Dr. Tyner, I'm a great surgeon, I'm such a great surgeon. What? Let me show you my microscope. Come to my office. Let me see. You see what you did. I said, give me your finger. And he said, what do you want? I said, give me your finger. And the guy said, no, I'm not going to give you my finger. What do you want? I said, give me your finger. You don't mind if I cut it off, do you? Listen, I'm a great surgeon. I'll use a microscope, and I'll put it back very nicely. You know? That's what you're doing to the buccal plate blood supply when you open a flap. So even though you put the tissue back, it hides and masks what you did, so you think you didn't do any harm. You're doing harm. Take a look. This versus this. 1 millimeter is acceptable, and we can get down even less, as you'll see. So we have alternatives. So how to extract a tooth? Real simple. Take a type 1 defect. You take this tooth, although it looks pretty good, it's broken, as you'll see in a moment. It's fractured. Got sent over by his dentist. We made a temporary for him real quick. You don't use a periosteal elevator to take a tooth out. You don't start separating the bone, the tissue away from the bone. You use a 15C blade or some smaller blade, and you're going to go in and make the turn. You're going to then go and use special forceps. Use like Salvin Corporation and others have these extended tips. Titan, other companies have it. Go get these extended tip forceps. Not the 150 and 151s. Those are for horses. You work in a farm, go and use them. Right now, this is the kind of forceps that we use. We take it out, and you notice now I can grab the buccolingual. This is a simple case. We'll talk about what happens if you fracture it above this later. But now I can take it out, rotate it out. So I'm just going to go through this quickly, place the implant, where to place it, how to place it. This was gone through already. We're going to go, and this is the key. You have an intact buccal plate, and you have the wall, right in the bundle bone here. Now what you do is you start out with a starter burr. It could be a round burr or a starter burr, from every company has it. And you're going to go about 2/3 up the root and perforate through here. This is one of the key tricks to doing this properly. Even though your first drill might even look at a bad angle. It's coming out the front. But what you're doing is breaking through the cortical bone. Then you're going to go in with the make that opening. Then you're going to go in with the 2 millimeter twist drill, holding it towards the palate, see, right at the cingulum, and go up the palatal wall. That engages a lot of extra bone. Instead of just bone up the apex, which is maybe 4 to 5 millimeters, now you're getting all this palatal bone and to engage, and that's why we lock in so well. And we use tapered implants with aggressive threads. That's what we do. Place it in as you see here. Make the temporary, get good support. You should have full support, no blanching. You're just putting back what was there. Now you want to do a bone graft in there. We're going to talk about why in a moment with small particles. We're going to put a bone graft in, but you can't get to it. You should also steam clean this, as you can see. Steam clean this. So we don't want any rouge. We don't want any pumice on there. We're going to steam clean it. We have it finished out of occlusion. It should be out of occlusion in centric and out of occlusion in excursions. We then take it off. We can't get the bone graft in, so we take it off, and the idea I had years ago was to put on a straight helio abutment. After the crown is made, completely ready to go in, excuse me, you pack your bone graft in. We'll talk about that, which bone graft in a moment, but mineralized small particle bone graft, we want to keep the shape, so certainly mineralized bioas or mineralized bovine bone is one, but mineralized allograft also works, and we put that into the socket and with a straight cylinder on there, so you have access. Pack it in. Then after it coagulates, after 3 or 4 minutes, you slowly take it off, then squeeze your temporary back on, and the excess comes out. This is dual zone socket management is what we published on. Steve Chu and I published on this, and along with the Salama and Garber and so on. And what we do is we get the excess out this way, and we've engaged particles not just to the crest of bone, but above. And that's the key. As you're going to see how significant that is when we do this. I call it dual zone socket management, bone zone and soft tissue zone. Here's 1 week later. It's as if I did nothing. Now, we don't have time for me to show you dozens of cases. We have time to show you 150 cases, 200 cases. This is what we see over and over again. If we didn't get this kind of result on a fairly routine basis, it's not just one lucky case, we wouldn't be doing it, especially in New York, where everybody has the lawyer attached to their right shoulder. Got it? So we're not stupid. Well, maybe we are, but we're not foolish. So take a look. That's 1 week. 2 months. Notice hardly any change. Minimal to none. Nothing that's appreciable. There's 4 months. Same thing. Now here's a critical piece. 4 months, you see there's hardly any change. With it, this was 0.2 of a millimeter change compared to the other side. And you notice we see bleeding when we first take it off after 3 to 4 months. And we love this bleeding. I'm going to show you the research that we just recently published on this past month. When we see bleeding the first time we take that off, that means we got the epithelium and fibrous tissue to adhere to the temporary. Epithelium can adhere to any clean surface, and it does. If it's clean, that's why we steam cleaned it. And this is what it looks like. Here's the final crown in place, as if we did nothing. One surgical procedure at the time of extraction. So when the buccal plate's there, we're gung-ho. We're ready to go. One surgical procedure, I think most of us would take that, wouldn't we? We would, and most of our patients love it. It's the biggest practice builder that we ever did. People send other people to us just because they know that they're going to walk out with a temporary, if they have the buccal plate. If they have a buccal plate, and they walk out without a swelling, minimal discomfort, and they walked out feeling like, I can't believe you replaced this, and I look better than when I came in. Okay? There's your views. No big change. What was the reason? We supported the tissue, both with the bone graft in the gap and the provisional, and no flaps were ever done, so no interference with the blood supply on the buccal. There's the final case. Should we place our implant or delay? Therefore, it becomes the question, which is the big question today. Should we do it immediate or not? Well, we just published this last year, this multi-center study with a few names that you recognize here, Garber, Salama, some guy named Salama, I don't know, two of them, I don't know who they are. But nice guys, I met them once somewhere. And this is a multi-center study. And very quickly what we did is we measured the buckling dimension at 7 different points, all the way up the buckle of each surface. 1 millimeter, 2, 3, 5, 7, and 9. 4 treatment groups. Let's go through them quickly. It's published, so you can go to it. Take out the tooth. These are all type 1 cases. Do exactly what Uli Grunder did. He showed 1 millimeter change, remember, when he just put, in his control study, he just put an implant in towards the palate and put on just a healing abutment. And he showed 1 millimeter change at the top of the implant after 6 months. Group 2, no graft, but a provisional's on, just to hold the tissue out, but no graft in the gap. Group 3, you get a graft, but no provisional, just a healing abutment to kind of hold it in on top, but with the graft. And group 4, the whole ball of wax. Let's put like I just showed you, graft in and the provisional, okay? So that's group 4. So let's see what our results are, all the way up the front of these teeth. Okay, gets graft and provisional. So group 1, we'll call it control. It's where you just put the implant in, and you just, no provisional and no graft. Now, if you take a look, this is really just flapless surgery. What was the dimension changes of the ridge? At about 2 or 3 millimeters, which is where Uli Grunder measured. What did he show? 1.0. Well, 1.1. Yes. 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 1 millimeter I can live with. And that's without a graft or a provisional. It also verifies that we're showing the same things that other great researchers in Europe are showing, the guys like Uli and so on. So we are starting to see that you just take a tooth out without opening a flap, and the buccal plate's present, we get about a millimeter dimension change. We'll come back to that millimeter. So what's interesting is let's see what happens when you put a graft in. I mean, when you put a provisional on, it's a little better, under a millimeter change. Notice on top, you still have the same 7/10 to a millimeter. The bone graft, there's no bone graft in there. Put a bone graft in, look at what happens to it seems to hold the ridge out a little bit. And this is good. Now let's do the graft and the provisional. Do they act together? And yes, they do. What are those numbers there? You know what those numbers say. 0. That means that half the cases were above 0, and half the cases were below. That's the average. Yes. That's why you just saw what you did, and that's why we see over and over again that you can do this if the buccal plate's present and you put it towards the palate, you graft the socket, the gap, and you put a provisional on with the normal contour. Wow. So you can all stand and feel real good about yourself and now know that you can leave right now knowing if you do this and know that your team can do this, you're going to be able to do immediates. So immediates only take place with the right team, and I couldn't agree more with Dan. Make sure you have the skilled team to do this and pick the right case. What type of bone graft material is still open to question? And Danny went through this, all these different materials. I couldn't agree more. We don't have this down. If we just want shape, some mineralized bone that doesn't go away is definitely the way to go. Otherwise, you can use almost anything here. We're not sure. The group that we put together did not specifically talk about one type of graft material. It was any type of small particle mineralized graft. It was not standardized. But I will tell you that they all worked. Take a look at Philip. We have some cautions, though. Philip came in, he was sent over by his general dentist. He fractured the tooth that he was holding this piece in. You see the fracture up here? You don't see it? Yes? Got it? Tooth comes out, but now you have what? Now you got a problem getting the root out. Do you open a flap? Do you open a flap? Please say no. Please don't open a flap. No, it means different ideas of how to get it out, simple things. We use long diamonds. Brasileir makes these. I don't have any rights to any of this stuff, but an 859 surgical length burr. You go in and right in the ligament space, you go in, back in here, go right into this ligament space, interproximally and palatally, prep that tooth away from the bone, and then use small elevators. You need one set like this. This is Salvin periodontal ligament, PDL elevators, but Salvin has them, Euphridi has them, a few places have them. They all have these now like one set. So you need one set of these and you're done. And that's it. And they look like periotomes, but there's a little curve. And now they come flying out. And the root tips come flying out, and that's what you want. Place the implant in, just like I showed you, towards the palate, screw down. We do not do cementable temporaries. No cement in the ceiling. Place it to the palate. After you got it, place it to the palate, put a straight healing abutment on, pack the bone, as you saw, and put the temporary on. Squeeze the excess out. The patient walks out looking just like this on the right, with the graft in place on the right. You can see that. Now, take a look at this. This is 1 week later. It's like nothing happened. Let's take a look later down. 4 months later, this is what the tissue looks like on the left. But look what happened. When Steve took off the temporary, look what happened. The bios didn't go away, of course. Now, sometimes it just stays inside the tissue, but because there was adherence of the tissue to the epithelium was adhered to this, the particles couldn't escape. So they got stuck in there, see? Now, if you look carefully, look at this one spot here. Look at this one spot right there. That's this little piece working its way out. It's innocuous. You would never even notice it. So it's slowly working its way out. So Steve said, "Den, should I take out all this stuff?" I said, no, don't touch it. Let it come out by itself. Let nature kind of do its own thing. There's no problem. Take a look at the tissue on the outside. It's perfectly healthy. That's perfectly healthy tissue. Let it work itself out by itself as it wants to. So we watched it for a while. Steve made a beautiful crown. We gold plated it. And even though the final crown was cementable, the tissue was sculpted beautifully. And notice hardly any change took place. Beautiful. But see, the particles slowly worked their way out after we couldn't wait any longer. And we basically put this in with these particles still there and working their way out. After 8 months, we said, we got to finish the case. So let's just do it. There's no harm. The tissue looks great. Look at the tissue response. Beautiful. So we put it in and finished the crown. There's the final crown. One surgery. This one was cemented. There's the pre-op what the patient walked in with, and there's the final case on the right, just in case you can't tell. How did it hold up? Here it is 3 years later. Held up perfectly. No real problem. 3 years later, even with those particles up there, that's really still looking pretty good, and the shape is still pretty good. Now, by the way, something that came up before, notice what we didn't notice at the time. We were looking at the buccal tissue. Look at the incisal edges, by the way. Look at the incisal edges. Notice the difference? They're slightly different. Let's look at this. Here's the day of insertion of the new crown on the left. They're even. What do you see here? And Daftari and Odette Bahat, Ferry Daftari and Odette Bahat have been talking about this due to attrition and wear and change in the adult. This was an adult. It wasn't a growing child. And this is something we have to address, but it's not for today. Slight. And he didn't notice it, and we didn't either. I just happened to notice it when I put the pictures together. It wasn't even noticeable to us. And the patient wasn't complaining about a thing. So which graft material to use? We're not sure. It's still open to discussion. Do we want something that the body can get taken away, or do we want something like Daddy says that stays there and keeps the tissue thick until it works its way out? Now, we looked at also the periodontal free gingiva. And what happened here is we looked at the gingival third, the middle third, and the incisal third. And we just published this last year, 2015. Steve was the first author on this. We looked at the effects of bone grafting on provisionals, and we looked at the thickness of tissue here, see? And you notice that for group 1, with no support at all, we were basically, the incisal third, which is on the right, was only 1.2 millimeters thick. That's going to be thin. The middle was 1.8, and 2.3 was at the gingival margin near the implant. Now, notice Van Brackel's work and Ronald Jung, they did this work that showed about 2 millimeters. This white line is what we need to get to, so the tissue, you don't see the dark metal through the tissue. If you add the temporary, notice our thickness of our free gingival was deeper. The incisal third is always going to be thin, but the middle and the apical third, we want to be thicker. Add a bone graft, excuse me, add a bone graft, it gets thicker. Do the provisional and the bone graft, look at the difference. Oh yeah. Look at the difference in the thickness. That's why we want a graft. It's to get this tissue to be thicker, 3.1 millimeters. That's equal to my piece of sashimi, right there. I don't have to put a piece of connective tissue in. We don't do that because we don't find the need for it. These cases don't need any extra support. So why open the periosteum? Why make it more difficult surgery? Why go to the palate and get another piece of tissue or to the tuberosity when you don't need it? I don't need it. I've got it right here. thickening the tissue enough for us to not worry about it. That's the winner. So it's for shape that we want this. What about bleeding versus no bleeding? We went back and looked, well, we had bleeding the first time we took off the temporary, which was about 3 to 4 months after we did the surgery. Take a look at Kelly. Kelly has an apical fistula too, but the buccal plate's intact except for that one apex. We cleaned it out thoroughly, made the temporary, like as I showed you before. And here's what we have. We're ready to put the graft in. We placed the graft in also. This dries up. Look at the beautiful contour at 4 months. The crestal bone was intact. Now, 4 months, the fistula dried up. We're ready to take this off. And what do we see? We see bleeding. So just to see how this worked, what we did is we took this off. We looked where this red zone is. We saw the bleeding there. See the red? Well, we sent this to Mark Reynolds and Hanai Saito down in Maryland, who have access to scanning electron micrograph, and we asked them to look at this. Now, this looks like the moon, doesn't it? That's what a polished temporary looks like. It looks like the moon surface. It's not. Look at no bleeding. You don't see any cells. Some openings, some craters, but nothing, 1000x. Let's look at the area where it was red, right next to it. Notice this fibrous attachment, and you see the fibroblasts going into the openings. A beautiful picture to show that's why when you take these off, you pull on these and you see bleeding. So this shows you can get adherence on the electron microscope, shows this beautifully. Scanning microscope shows this, and you can see that we actually have attachment going right into these openings. And that's what I want, because let me show you why. And we showed that was the immunofluorescent stained it with gold, and we showed that shows fibroblasts, and you can see that the fibroblasts are all over the surface. Now this just came out, 2016, just came out this week. So this is right off the presses, as they say, where we had bleeding versus no bleeding. Really, to summate it, you take a look at this dimension. The red is where there's bleeding. I'm sorry, the red is where there's no bleeding, and this is where there was bleeding. If you take a look, the thickness of the tissue, the buccolingual dimension of the ridge, was greater when we had bleeding. When we didn't have bleeding, it was much lower, all the way up. If you notice the bottom, when you're yes, the green is bleeding, what you see when we have bleeding, these are positive numbers. In other words, the tissue, those were our best results. Where we had no bleeding, where we didn't capture it, those were our worst results. So it shows you that this capturing it, allow it to mature, is the key. The idea is wait 3 months. Nobody's in a rush to have a beautiful temporary. Wait 3 months, then when you take it off, it seems to be able to withstand the ripping, and it matures. You don't want to do it too early. That seems to be the key. So no bleeding versus bleeding. Again, you take a look at where there's bleeding, we have much better buccolingual dimension and change and better height. Just really good. So you can read the article, it just came out. So one abutment one time, as my great colleagues from Atlanta have talked about this, one abutment one time. You can't always do that though, can you? It's not always possible. And this was a nice term, and it does work. Get the epithelium and adherence right to the abutment and don't change it. Leave it alone. You get supracrestal adherence. Beautiful. But we can't always do that. None of these cases had one abutment one time. They were multiple changes. So one of the things that we may be looking at, and the term I came up with instead of one abutment one time, would be to what? One clean abutment the first time. And let it heal for 3 months. That may be okay. And that seems to work, because that's what all this data shows. This was all one clean abutment the first time. And here's that case at 5 months. The one that had the tear, we made another temporary and put this in. One with the fistula. Here's the final crown, screw down, and a regular crown for the right central. And here's the case finished. Fistula dried up, beautiful tissue, and I think we got a decent result. So this is what we do for a living. This is our daily work, so to speak. We do this so often now, it's amazing how predictable this is. We said we can't believe that we did it any other way all these years. I say it to you openly. And there's that we just showed you the proof of it. So this is what the patient came in with a draining fistula even. Now remember, I'm not going to go back to the apex. I'm going to clean it out, but the crestal bone was there. Once the tooth is out, I make that decision. And the CAT scan showed me that I had a small lesion at the apex. It wasn't blown out. Like Brad showed some of the lesions that are big, that's different. Here, and I'm also going where? I'm not going out the apex, I'm coming up the palate. I'm going up the palatal wall about 2/3 up of the socket and penetrating and putting the implant there. Oh yeah, totally different. And here's the success. There's the final case. Now, what about abutment selection? This is still open for grabs. Marcus Blatz talked about color a little bit, of course, and you know, we talked about white. That's always great, certainly better than the gray titanium. But if you look at some of the work at Harvard by Shigeki, she showed that the gold color, yellow, and pink actually may be the best solutions. Better than even zirconia, white zirconia. Now we have different colors of zirconia today, of course, but this is showing better. So I'm presently at Columbia, we're presently doing a study with Harvard to look at this on abutments, looking at the pink color, and it should be ready in about 3 months. The data should be ready, and we're looking at different color abutments and using a spectrophotometer to see which color is most natural, equal to the adjacent tissues. So this is something still pending, but there's no question that that's something we have to look at. So when do I do immediate? When do I do early, like Danny does? I do a lot of cases like Danny does. I love what he came up with. What does it allow you to do? It allows soft tissue to heal over 4 to 6 weeks. The soft tissue heals, and then you have more tissue to go in and place the implant with, so and do whatever grafting you need. But I use that for type 2 defects, where the buccal plate's missing. Type 1, this is what I do. So type 1, where the buccal plate's there, I'm doing immediates. And the papilla never goes away. The papilla never goes away. The papilla never goes away. If it's there and the adjacent teeth are healthy, from day 1, the papilla gets faked out because you're putting a temporary on. The papilla gets faked out thinking that the tooth is still there because the contact point is still there. So if the attachment is healthy on the adjacent teeth, you're fine. And when do we do delayed? 3 to 6 months, exactly what Danny said. With it underneath the sinus, over a nerve, where the bone has to fill in first. You can't go apically. Now, all of Dan's beautiful cases were initially in the front of the mouth, in the anteriors, where there's always some apical bone to the floor of the nose. When you get to the sinus or to a nerve in the back, you got to wait. If you don't have a buccal plate, you certainly don't put an implant in, not that day. So the last part, does gap size matter? This is real interesting. How am I doing time-wise? I know I'm trying to move fast to get everything done. Is this Coachman time or my time? Which one? Okay. All right. Take a look at the gap. Let's have some fun with this now. How does that heal? Is an implant, how does any gap heal? Or how does any socket heal? We know that. The bone fills in and bone fills into the socket. Now, of course, with a certain amount of dimension change. But the socket fills in. Now, take a look at this case. I put those implants in, and we made it temporary. And how does that fill in? We'll come back to that. If you look at the work of Carlson, Warren Gottfredson, Knox, Cordell, Mefford, Stentz, Akimoto, and Becker, you look at all these classic papers, and I looked at them very carefully. They all said, don't do this. Never do this. We stopped doing it. I stopped doing it, or I didn't do it for years because all this data, I'm evidence-based. I am as evidence-based as anybody. I'm academic, just like Danny and many of you, and and I'm very biologic. And I said, you know, I'm trying to show everything makes sense biologically, or else I don't do it. I said, there's something wrong, because there are guys that have been doing this immediate stuff, and they don't seem to be getting into trouble with the fiber seam, if it is a fiber seam. Something's wrong. And so I went back and looked at all these classic articles. You've all seen these articles. You've seen them talked about. And they all talk about the distance. If the gap is greater than 1.5 millimeters, and Tom Wilson showed this in humans too, anything greater than 1.5 horizontal gap, you get a fiber seam. Even as little as 0.5 for some of them. So why should we ever do an immediate? We should never do an immediate, if that was true. None of these cases would work. Or they'd work, but they'd have a defect. What's the defect? They'd have a buccal tissue, they'd have fibrous tissue on the buccal, in the gap. But let's go back and look at this. You take a look at like Akimoto and Becker's article. They did no gap, 0.5 millimeter gap, 1 millimeter gap, 1.4. And then they looked at it, and they locked it into the apex, as you see on the bottom right, and opened up the top. Now, the right is the control. The red is bone, and you notice that they got beautiful bone in the control. Of course, no gap, everything's fine. But look at the test. This is exactly what the concern is. That white is fibrous tissue. See the top? Fibrous tissue. So we shouldn't do this, should we? Oh, that's why we stopped. I was saying at the time, 10 years ago, I said, don't do this, guys. You've got a flaw here. But wait a second. What was wrong? What did they all do? Let's go back to Akimoto's article. What did they do is they put the flap back over the top of the defects. They didn't let it heal by secondary intention. All of the primary coverage without a membrane. Now, similar to the great work that Danny's done in GBR, incredible stuff all of his career, showed that if you put a membrane in, you know that you'll get bone up against the implant because the fibrous tissue from the flap and the epithelium are excluded. So only the bone then comes across and fills in. This is well known by all of us, right? I hope. What's the difference here? We are leaving, in the case I just showed you, like here, what did I do here? Nothing. I didn't put anything in there either. Just put a temporary on. And yet look at the healing. Now the question is, what's up against the implant? Is it fibrous tissue in there? It can't be probed. I probe it hard. I can't probe it. Or do I have a thin layer of fibrous tissue, histologically? Because it might open up in the future. You say, well, who cares? Well, it might open up periodontally in the future. I don't want that. I want long-term success. So the question is, what's up against the implant? And what bothered me is that we don't know what happens if you leave it open to heal by secondary intention. And no flaps, no primary coverage, just like I did here. So I kept saying, you know, biologically, it should not make a difference. Gap size shouldn't make a difference. If this gap, if the bone is going to heal and the buccal walls are present, as it is here, it should fill in with bone. Why? Let's take a quick look. And here's the final case. It looks nice, everything's fine, and the bone looks good. And the bone looks good on the x-rays. So it comes down to primary flap closure versus secondary wound healings. To make a long story short, it's as simple as this. If you get a clot, as you do when you take a tooth out and your bone is there, like on the red, where does the epithelium and the connective tissue from the top are retarded? They're slow. They don't just cross over. Normal epithelial growth is about 1 millimeter per day in the body, 0.5 millimeter to 1 millimeter per day. Yet how long does it take for a socket to epithelialize when you take a tooth out? About how long? What's been shown? It's only 8 millimeters. It should be, a week should be enough. If it was skin, a week would be enough. Get a clot, and the epithelium goes over or under the clot. Here's the key. If I cut myself now, and I get a 10 millimeter scab, I get the scab, and then the epithelium goes over or under the clot. Over or under. Has to go under, because the epithelium has no blood vessels of its own. The clot is non-vascular. It can't go over the clot. It's just fibrous. It's just fibrin. It's a scab. So what happens? Excuse me. What happens is it goes under the clot and then it peels away. Right, first at the edges and it peels away. That only takes about 5 to 7 days. If I had a 10 millimeter defect. So if I have a 10 millimeter socket diameter, it should only take 5 to 7 days, but it doesn't. Amler, as far back as 1962, showed that it takes what? 3 weeks. It takes 3 weeks for it to epithelialize in humans. Why 3 weeks? Because the blood supply is not there for it to cross over. See this beautiful red picture? That's dead cells. It's fibrin and dead red blood cells, no vessels. The vessels have to come from the side and the apex, and it can't go any faster. So it's going slow because it can't go in. It tries to go down, but it can't because the new vessels coming out of the bone by contact inhibition stop them. So it's got to wait its turn. So the blood vessels come through first, just like any other socket, and that's what happens. So you watch what happens here. This fills in from the sides, and this epithelium here can't go any faster. And that's what happens, and slow. And that's because the vessels take a few weeks for it to come across. That's why it averages 3 to 4 weeks. Okay. Now what happens if we decide to put an implant in the middle? We got the exact same socket. No flaps. We put an implant in the middle. What's going to get there first? You get a clot. And what's going to get there first? What's going to get there first? So if we put an implant in, what's going to get there first? The connective tissue is going to get there first because this is slow at the top. It can't go down. Got it? That's the difference. No primary closure, no flaps. Let it heal by secondary intention. And now you should have bone filling in there just like any other socket. Just happens to have an implant in the middle. Proof of principle. I published this with one case report. I don't have time to show it all, but let me just give you the history in this. We took a tooth out on Mr. Prolongo. You should notice it was a very wide defect. We added an extra implant. It was a low smile line, or else we would have made a Pontic here. Look at the gap. What do you see there? 4.2 millimeters. More than twice the size of anything that anybody said was the max, 1.5 to 2. This was 4. Nothing was done except put a healing abutment on. 5 months later, it's filled in with tissue. And then we sculpted the tissue, Steve sculpted this tissue, and loaded it. We had this loaded. There's no pocket there. There's no pocket here. And this is what it looked like before. And it was loaded for 3 months. And Steve called me in. He said, Dad, remember we put this in here to see what it looks like? It looks great. I said, wow, that's great, but we still don't know what's up against the implant. I said, well, maybe we should ask him to donate it to science. I said, Steve, you know, that's asking a lot. So I said, we asked ethicists and we did all kinds of stuff, and basically, make a long story short, he was a wonderful man, and he says, I'll donate this to science. Since you have it so well documented, every week or every month, I'll donate it to science. So he let me take it out with a small piece of bone in front, and he donated this tooth. Now, if you look, here's careful. Look at this number. Here's the scan before we took it out. What was the distance? 4.2. Now it's 3.1 millimeters of bone. It was a gap. Yes, we lose the millimeter. Yes, that bundle bone was going to change. But his bone fills in behind it. And it may not show at the 8-week level. That's why Dan's research has to be questioned in terms of, not that it was false, just in the 2 months, it won't show. It's not going to be showing up on an X-ray so quickly in the scan. So understand that what he has, the space was good, but it was filled with fibrous tissue, 5 millimeters. I think, and we can talk about this later perhaps, but that basically was filling in with bone, just wasn't calcified enough to show on the X-ray. Here is why 1 millimeter goes in, just as we talked about, but notice it fills in with bone. But what's the key? What's up against the implant? Well, we took this piece of bone out, thanks to Mr. Palongo, and he donated it to science. Let's take a look. Here's the top of the implant. This has never been covered. You had a space here, that's the epithelium. That space, that white space, is my sounding the bone. I shouldn't have done it, but look at the epithelium up against the implant. Go a little further down, there's the connective tissue. And where would the bone be on this implant? About the first thread. There, my friends, is the bone, right up against the first thread, with a 4.2 millimeter gap. It's only one case, but it shows what can happen, and it's proof of principle. And I hope you all appreciate what our patient gave. Mr. Palongo, Anthony Palongo. Hope you appreciate his donation to science. So how does this affect us clinically? This is the change. There's another change. Besides in the front of the mouth, we're now doing this in the back. And Dr. Smith and I published this A, B, and C version of different sockets and molars. A is where the entire implant is surrounded by septal bone. B is where it's supported by septal bone but is now in the gap. Okay? And C is the septal bone doesn't hold very well. You have to go wider with the implant, and you engage the buccolingual walls. So let's take a look at this real quickly. Take a look at this socket. I just threw this in. This is a case I did at school, so I had the patient be able to come back every week or two. So this is a broken tooth. You can see it's all diseased. So we're going to take it out, and we take it out in pieces. We trisect and hemisect, take it out. No flaps. There's the 3 pieces. And we have this. So we engage this middle septum. Wasn't much, but we engage the middle septum. And of course, there's dehiscence on both sides. Put a healing abutment on, outside of the tissue. We put it down towards the septal bone, about 3 millimeters below the buccal tissue, just like any other implant. And here it is at 1 week. What do you see? You see the clot. That yellow is clot. We tell the patient to stay away from it, just like any other socket. We didn't even put a temporary on this. We didn't do anything except a healing abutment. And notice this is what 1 week looks like. This is what 2 weeks looks like. It's starting to get redder because the tissue, the blood vessels are coming in to the clot. 3 weeks later, still red. It's not keratinized yet. Here it is at 5 weeks. Notice the keratinization starting. Once you get epithelialization, it takes another 28 days to become epithelialized. And here it is at 8 weeks. And here, my friends, is 12 weeks. Got it? And if you look at the extraction socket at 12 weeks, notice it's now keratinized, it's filled in, and we have everything we need and can finish the case. And there's also, we can go wider. Take a look at Haesuk, this tooth has to come out. And we're using wider implants. And with pink tops sometimes. That's something else that we're looking at in terms of the color. So we're taking a look at this, and you see we're using wide. It's 6.5, not 4s and 5s. Go to 6. Okay, fill up the gap. There you see it. Here it is healed. Here it is at 5 months, perfectly healed. Take it out. We see the bleeding. And then we just do the crown, and everything is actually perfectly healed. 1 surgical procedure. Here's a crack. Now, this one's different. You see the crack in here? We're going to take this out. And the buccolingual dimension is going to have to be engaged. So what do we do here? We go wider. Listen to this. This implant's 9 millimeters wide by only 7 millimeters long. It's wider than it is long. And we're seeing that these work. Wow. Has this made a paradigm shift in our thinking? Yeah, if all the walls are there and we can get primary stability, and we do, this is what we do. Just go wider. Here it is at 1 week. And here it is at 6 months. All filled in. Looking good. 1 surgical procedure. So we have a 96, in our study, which we're ready to publish this. In all our immediate molars, we're at 96%. This is our office. 96% survival. And by the way, I just threw this in real quick. Give me 2 minutes on this to finish off the discussion about incision design. I personally don't like to open papilla if they're there. Why? Because if you open it up, you can lose 0.5 to 0.7 millimeters of bone. And to a papilla, that's a mile. Remember my 5 millimeter rule? At 5, you usually get bone. I mean, the tissue filling in the gap. At 6, what happens? You lose 45% of your papilla. There may still be a scallop, but they're deficient. So 1 millimeter is a mile in the papilla zone from vertical height. So this is how you do it. You can make it small if it's small, or you can go wider. Tony Sklar, this is from his textbook, but this is a standard procedure in our office if the papilla is present and I have to fill up the buccal. Or go wider even. You can do all the grafting you want and use the elastic fibers up here. Now people say, well, Dr. Tano, I don't like those verticals, just like you get the scarring. In fact, Danny used that term. But it's not scar. Everybody uses it. I used to use the same term. It's not a scar. It's a groove. It's a groove. Why is there no scar? Some of you heard me lecture on this before. It's not a scar. Gingiva doesn't scar. We're so lucky to be dentists. If I do a gingivectomy on you, where's Garber? You can be nice to me? Dave, you promise me? I'm going to do a gingivectomy on David. I'll do a gingivectomy, and I come back in 8 weeks. Do I see any scar? I lop off the tissue, and 8 weeks later I come back. Do I see the incision designed? No. Attached gingiva doesn't scar. Why? My students know there's no elastic fibers in gingiva. Mucosa scars, skin scars, but gingiva doesn't scar. That's why we get away with murder. We can lop it off with a burr, lop it off with electrosurge, do whatever we want. No scarring. So what is it? It's a groove. And here's the mistake that people make if they do verticals, especially here. They try and put the temporary on. Then you can't close it. You can't pull it because there's no elasticity. So you don't put a temporary on. If you do a closed, this is not an immediate socket, this is a healed ridge. So if you want to graft this, like Danny at 8 weeks when he goes back in, I would leave some of the papilla alone and just do this kind of incision. That's clearly a modification, and he's welcome to do what he does, along with a lot of the Europeans. Great clinicians. No one better. We know that. No one better. And I say that openly. But if I don't have to open a papilla, I don't want to. I only risk loss of it for access. This does what I need. So if it's there, I leave it there. And Gomez-Roman showed us this in terms of papilla taking or not. And then look at the range. This is this article that Danny quoted this morning. I put this in because what you see here is the wide flap, meaning with the papilla, you average 0.7 millimeters versus 0.2. I'll take the 0.2 and the bone next to the incision. But look at the range, up to 2 millimeters. I don't want to be the patient that lost 2 millimeters of bone on the adjacent tooth. That's a black triangle. So look at the range, the crapshoot versus nothing. So we do this, papilla-sparing incisions. We want the smallest opening. See, we don't want to expand it. And then this will heal normally. If you expand it with a big temporary, it's going to push it all out. So this is what you don't want. You don't want something that's going to not be able to close. So nothing like this. We want something small diameter, straight diameter. So let's finish my presentation with this. Notice this is a depression, almost like you would have at 8 weeks. We're now going to build this up. This happens to be congenitally missing, but you can make it wider. This was a small one, so I didn't even go wide. But look at the papilla-sparing incision. See that? Papilla is untouched. Open it up, put the implant in, graft it, similar to what we do, membrane, graft material, and close. Now look at the verticals. And they're there. And take a look at it. We're going to do the same thing to the other side. Just quick. And they're pretty well adapted. I got the implant in nice. And here's the final case. The grooves are not hardly visible, and you're sitting on the guy's chin looking at it. And when you take a look at this, you can hardly see this. When he smiles, he was not aware of it, and neither would you notice it. See it? And yet there were 2 verticals there. The key is what? Don't expand it. Straight cylinder, when you have a healed ridge, papilla sparing, let the straight cylinder heal for at least 3 or 4 weeks, then expand it with what? The pressure from your temporary. And there's the before and the after. And I think we have a nice result, as you see here. So future research is going to be on soft tissue, adherence, different types of supragingival tissues, platform switching, thickness of tissue. All these things are part of what we heard all day today, so I don't have to go back into this. So I want you to I'll leave you with this. If you see, I'm thinking biologically all the time, just like Danny is and just like other teachers are. We're trying to make evidence-based approach, and it's done. Think biologically. I didn't want you to spend too much time on me, and thank you. Thank you both.